Before starting the management part, let us understand the pathophysiology of the acne scar. So, acne scar is a part of natural wound healing which is characterized by three stages. Stage of inflammation. This inflammation is because of process of acne itself. Second stage is stage of the granulation tissue formation. Third stage is stage of remodeling. So, when the damage occurs in the papillary dermis, scarring usually mild. When it occurs to the deeper dermis, severe scarring happens. In the pathophysiology, there is a role of the innate immunity with the overexpression of transforming growth factor beta 1 and beta 2, along with the matrix metalloprotein, especially the matrix metalloproteins 9, platelet derived growth factor, prostaglandin D2, histamine, tryptase, and interleukin 2 and 6, with a tendency towards the Th1 response. So depending upon whether the collagen overproduction which causes the hypertrophic scar or the marked collagen and elastic fiber damage resulting in the atrophic scar. There are the various types of acne scar depending upon the level. It can be macular the flat, depressed or atrophic or elevated. Macular or the flat scar itself can be edematous, hyperpigmented or hypopigmented. The most common acne scar we encountered is the depressed or atrophic scar, which can be ice-pick scar, rolling scar, box scar, linear scar, lipoatrophic scar, distensible or non-distensible. Elevated scars are hypertrophic scar, keloidal scars, papillary, and the bridging scars. So the most common scar, as I told, is the atrophic scar, which is mainly ice-pick scar, box scars, and rolling scar. These ice-pick scars are the deep and narrow, which is at less than 2 mm depth, and it has the apex broader than the bottom. It is sharply demarcated tract which extend deep to the dermis. Box scars can be shallow or the deep depending upon the depth. Shallow when the less than 0.5 mm, deep is when the more than 0.5 mm. It is usually round to oval depression with a width of the 1.5 to 4 mm. with a sharply demarcated vertical edge and a flat bottom. Rolling scars are the widest scar more than the 4 to 5 mm. It is also shallow or the deep and it depresses with the gently sloped edges, and it is caused by the dermal tethering. Acne scars can be graded quantitative with the help of the Goodman's and Barron grading scale, which can be grade 1, 2 or 3 depending upon the severity. So grade 1 is a macular, which is the edematous, hyperpigmented or hypopigmented. Grade 2 severity is a mild, which is acne scar which is not visible at a social distances of 50 cm or the greater and is adequately covered by the makeup. Grade 2 is a moderate severity, which is obviously visible at a distance of 50 cm or the greater. But when scar is manually stretched, it disappeared or flattened, and it is not adequately covered with makeup. Grade 4 is a severe scar, which is obviously visible at a distance of the 50 cm or the greater. When we try to manually stretch the scar, it won't disappear or it won't get flattened, and also it won't be able to adequately cover with the makeup. Various techniques are available in the acne scar revision. These include some medical therapy, chemical agents, surgical therapy, mechanical devices, laser and energy-based devices, regenerative procedures, and the tissue augmentation. Medical therapies include topical retinoids, topical and skin lightening agents, intralesional steroid. Chemical agents include chemical peels, cross techniques. Surgical therapy includes subcision, punch excision techniques. Mechanical devices include microneedling, dermabrasion, microdermabrasion. Lasers and energy-based devices, it can be the ablative lasers, non-ablative lasers, and the radio frequency energy devices. Regenerative procedures include a platelet-rich plasma, nano-fat transfer, and tissue augmentation in case of the severe atrophy. It can include synthetic fillers, autologous fat transfer, and autologous dermal transfer. In case of the macular acne scar, which is erythematous, hyperpigment or hyperpigmented, the modalities available for the treatment of the erythematous macular scars include chemical peel, pulse dye laser, intense pulse light, non-ablative lasers. In case of hyperpigmented macular acne scar, it can be treated with the help of the chemical peels, Q-cyst anti-YAG lasers. And hypermacular acne scar can be treated with the help of the TCA cross, fractional CO2 lasers and the excimer lasers. The most common acne scar is atrophic. In case of the ice-pick acne scars, we have options for the subcision, TCA cross, micropunch technique, microneedling, radiofrequency fractional devices, CO2 lasers. In case of boxer scars, subcision, punch technique, microneedling, MNRF, fractional CO2 can be done. In case of rolling acne scars, subcision, punch technique, microneedling, MNRF and non-ablative lasers can be used. In the case of lipoatrophic acne scar, it can be treated with the help of the subcision, fat transfer, fractional CO2 lasers. The hypertrophic scar, which is commonly encountered in case of acne scar, the papillary scars, it can be treated with the help of intralesional radiofrequency and the Ilvium class laser. The hypertrophic acne scars can be small, large or multiple. In case of the small hypertrophic acne scar, it can be treated with the help of intralesional triamcinolone corticosteroid with either with the hyaluronidase or the 5-fluorouracil. It can also be treated with the help of intralesional radiofrequency ablation and the intralesional cryosurgery. In the large and the bulky hypertrophic scar, the options are available: intralesional radiofrequency ablation, intralesional cryosurgery, fractional CO2 laser with the topical dermal drug delivery, surgical debulking and the radiotherapy. In case of the multiple hypertrophic acne scar, we have options with the fractional CO2 lasers with the topical dermal drug delivery of the triamcinolone, cryosurgery, imocumod and the pulse dye laser. So coming up with the individual's treatment part, first the chemical peel. Chemical peel can be, depending upon the depth, can be the superficial peel, which is used mainly for the mild grade 1 scar. Medium peels used for the moderate grade 2 to 3 scar, and the chemical peels used for the deep peel for the severe grade 3 scars. Superficial peels is safe for the all skin type and usually done in the interval of the 2 weeks. These peels include glycolic acid 35 to 50%, lactic acid, salicylic acid 30%, trichloroacetic acid 10 to 25%, and Jesner peel with the 1 to 3 coat. These Jesner peels include the salicylic acid, lactic acid, and the desorptionol. Each is 14%. There is a modified Jesner peel also, which includes the salicylic acid, lactic acid, and the citric acid. Other superficial peels are the pyruvic acid peel, retinoic acid peel, ferulic acid peel, mandelic acid peel, phytic peel, and the combination of these peels. Medium depth peels should be used cautious in the darker skin because of risk of hyperpigmentation. It is usually done in the once in a 6 months. These include glycolic acid 50 to 70%. Trichloroacetic acid 25 to 35%, pyruvic acid 40 to 70%, Jesner peel along with the 35% of trichloroacetic acid. Deep peels should be avoided in the darker scar in the one-time procedure, which includes the phenol peels, which is used in the form of the Baker's Gordon formula, which is actually the 3 ml of the phenol, 2 ml of the water, demineralized water, and the liquid soap and the croton oil. The principle of the chemical peel, it is a resurfacing technique which is used in the pigmentation improvement and the skin texture. It stimulates the wound healing and causing the collagen modeling. In case of dermal and epidermal hyaluronic acid, resulting in the improvement of the scar. It should be avoided in the active infections, dermatitis or the impaired skin barrier, and it should not be used in the case of any photosensitivity and the person is on the photosensitive drug. Usually, superficial peels can be done in the case of the patient on the isotretinoin, and deep peels should be avoided. Coming up with the procedures, before the chemical peel, patients should be primed properly at least 2 to 4 weeks before with the help of hydroquinone, kojic acid, and proper use of sunscreen. The area to be treated should be cleaned and then degreased with the acetone, and the peeling is applied with the help of the brush or the cotton tip. The picture shows the direction of the application of the chemical peel, which is usually starts with the forehead, then in the from the inner part of the cheek to the outer, or the both side, and subsequently. Endpoint of the chemical peel should be noted, which is usually erythema in case of alpha hydroxy acid like the glycolic peel, and endpoint of salicylic acid trichloroacetic is the frosting. At the end, it is neutralized with the help of sodium bicarbonate solution, or it can be washed off with the water depending upon the chemical agent which is used. It can be repeated at an interval of 2 to 4 weeks in general. Post-procedures care includes a mild cleanser, proper use of moisturizer, and the photo protection with the avoidance of the sun exposure and the proper use of sunscreen. Adverse effect of the chemical peel include the post-inflammatory hyperpigmentation, excessive dryness, melia formation. It can exacerbate the acne and may cause hypertrophic scar, particularly in the deep peels. TCA cross is another method to treat the acne scar. It is the chemical reconstruction of the skin scar in which serial local application of high concentration of trichloric acid with the wooden applicator to the scar. As shown in the picture, usually this process is done without any anesthesia. The endpoint is the white frosting with this wooden applicators. With the help of wooden applicator, TCA is applied on the individual acne scar, and the white frosting is seen as an endpoint. This forms a black crust in the 3 to 4 days and usually heals in the 7 to 10 days. It acts by the dermal collagen remodeling, and the concentration which is used in this treatment is usually 35 to 100% of TCA. Alternative, phenol 88% can be used. And there is another, the second image shows the another method to application of the TCA cross, which is called a needle bend technique mounted in the syringe. But this requires the expertise as to control the amount of the acid delivered to avoid the skin penetration and avoid the skin spillage. The TCA cross can be combined with the other modalities of the acne scar technique, and this method is best for the ice pick scars. Next comes the subseason. Subseason, it is indicated mainly for the rolling scar because of the dermal tethering. It breaks the fibrous strand, and it can be used for the ice pick and the box scars. The procedures require the infiltration anesthesia, and the area to be treated should be cleansed and sterilized properly. Instrument Noakes needle 18 to 24 gauge is generally used depending upon the scar. In this method, needle is inserted from the edge of the scar into the dermis. The bevel of the edge should be faced upward and is then moved backward and forward, and then moved horizontal in the fanning motion to break the fibrous strand. The end point of the procedures is the smooth movement of the needle without creating sound or the resistance. After the procedure, light pressure is applied to prevent a bruise and hematoma. The instrument can be used as shown in the figure with the use of the hypodermic needle, which is bent at the 90 degrees at a 2 angle. Other instrument which can be used is spinal needle cannula, and one other method for the subcision is the diamond shaped subcision, which includes a wide spread area of the acne scar, in which the diamond shaped acne scar is marked with the shape diamond shaped, and subcision is done from the all corners of the diamond shaped marking. Subcision is usually repeated in the interval of 2 to 4 weeks, and it also can be combined with the other technique of acne scar. It should be contraindicated in the bleeding diathesis patient on the aspirin and vitamin E. Complications of subcision includes the pain, bruising, hematoma, swelling, edema, induration, and persistent fibrous nodules and the post-inflammatory hyperpigmentation. Next procedure is the microneedling. So microneedling is a percutaneous induction therapy in which handheld rolling instrument with the tiny needles is rolled over the skin, which causes a multiple microinjury in the skin, leading to breakdown of the old collagen, induces the new synthesis of the new collagen. It is done by the various instruments, which includes derma roller, derma stamp, and the derma pen. A standard derma roller usually have the 192 needle with the help usually 200 micrometer length and 70 micrometer in the diameter. The needles is of the medical grade stainless steel, and it has available in the varied length from the 1.5 to 3 mm. Mostly the length used in the dermatology procedure is the 1.5 to 2 mm, and these needles are arranged 50 degree radially to the center of the in relation to the roller center. It requires the application of the topical anesthesia in the form of the eutectic mixture of local anesthesia. The area is properly sterilized. During the process, as shown in the pictures, with the non-dominant hand, the skin is stressed and the derma roller is rolled over the skin with the covering 2 into 2 inches in a one time, and it is moved around 6 to 10 times in the 4 directions, horizontal, vertical, and then diagonally. To increase the intensity, it should be frequency of passes should be increases, not the pressure. And in the bony areas like the forehead and the nose, lesser pressure is required. And the uniform pinpoint bleeding is the clinical endpoint. During the procedure, it forms 250 holes to 300 holes per centimeter square. It is best for the box and rolling scar and usually respond better for the fresh scar which is less than 1 year, and can be also combined with the peels. Intervals in between the 2 sessions is 6 to 8 weeks, and usually 5 to 6 sessions is required. The next procedure is the microneedling radiofrequency fraction. This is the device-based method in which the radiofrequency energy, which is high intensity alternating electric device, RF energy is delivered through the multiple needles in the fractional manner through the multiple passes with the adjustable needle depth, penetration, and deposition of heat, thus causing the microcoagulated thermal zone. The image shows the device with the handpiece which has the disposable needle cartridge of the variable. This depth of the needle can be adjusted manually with the depth 0.5 to 3.5 mm. The pictorial image shows the individual needle which is the insulated part. The lower 0.3 mm of the needle is non-insulated and usually the 0.3 mm in length, and this forms the microcoagulated dermal zone. It is done under the proper anesthesia, either topical or the infiltration anesthesia. As shown in the pictorial image, as the needle passes through the epidermis and dermis, it causes a mechanical injury without any thermal damage along the length of the insulated needle, leading to the pinpoint bleeding. This physical damage stimulates epidermal regeneration. The heat of the RF energy causes a dermal coagulation. It disrupts the collagen bond and causing inflammation and the intense wound healing, which result in the stimulation of the fibroblast, and the platelet gets activated by the endogenous collagen, consequently causing the growth factors and cytokine release. finally it results in the new collagenesis, elastogenesis, and extracellular matrix formation, which ultimately the result is atrophic scars is reoriented and the leveling effect of a scar happens because of the depression of the surrounding skin. In this method, multiple passes, typically passes is given to cover the entire dermis, with the first pass usually at a deeper level than the subsequent and with the less exposure time and the power. Rolling at the Boston scars responds better than the ice pick scars, and this procedure is usually done in the once in a 4 to 12 weeks. 3 to 5 sessions is required depending upon the improvement. The advantage of the MNRF that it is a color blind, means the chromophore independent, and it is effective, can be safely used in all skin type and has a less downtime and the more safe in the darker skin individuals. And it should not be done in case of the patient with a pacemaker or having the facial metal implant. The contraindication for the both microneedling and MNRF include verruca vulgaris, patient with the keloid tendency, solar keratosis, and history of skin cancer, having the uncontrolled diabetes in case of the pregnant woman, and history of the collagen vascular disease, neuromuscular disease, and patient with the unrealistic expectation. Before the procedure, precautions should be given. Anticoagulant and steroids should be stopped 1 week before, and if there is any active acne, it should be treated first before the procedure. If there is any history of the recurrent herpes infection, prophylactic oral acyclovir should be given. And proper priming at least 3 weeks before the procedure should be done with the help of hydroquinone, vitamin C, kojic acid, or even the peeling such as the glycolic acid. And proper counseling about the sun protection should be done before the procedure. Post-procedure may require the antibacterial cream or may require the systemic course of the antibiotic. Proper use of moisturizer and sunscreen. One should avoid the sun exposure, and one should avoid the use of scrub, loofahs, or any abrasive or the irritant cleanser. One should advise not to pick or rub the face, and if in case of heating, adequate skin cooling should be used with the help of ice pad. One should advise for the do not take the steam or any kind of fumes. Avoid sweating and exercise, and light makeup can be wear after the 72 hours of the procedure. Complication of the procedures include erythema, flushing, and the pain. Infection can be happen. Post-inflammatory hyperpigmentation. There can be increase in the flare of the acne. Scarring and the needle track marks can appear. Melia-like eruptions. Now comes the next technique, which include the punch technique, which is of the following type: punch elevation of the punch flotation, punch excision, punch grafting, and it is best for the ice pick and the box scars. Scar size less than the 3.5 mm should be size and the grafting, and the size more than 3.5 mm should be size and the sutures. A picture shows the all three methods done on the patient, which is the punch excision, punch grafting, as well as punch elevation. When the patient having a very close scars, it can be performed in the 2 or the more sessions. The complication of procedures include failure to take off the graft extraction, cobblestone appearance, post-inflammatory hyperpigmentation, ring a scar at the margin of the punch, and the widening of the suture line in case of the punch excision and suturing. This procedure also combined with the laser resurfacing technique. Lasers in the acne scar can be ablative, non-ablative. Non-ablative lasers are usually indicated for the mild to moderate scars, grade 1 and grade 2. Ablative lasers are usually used for the moderate to severe scar, grade 3 and grade 4. This ablative laser is usually considered to be the gold standard for the acne scar treatment. And non-ablative lasers usually use the thermal energy injury while in the dermis, preserving the epidermis, and ablative lasers causes destruction and elimination of the scarred epidermis and part of epidermis, resulting in subsequently remodeling and the collagen induction. Ablative lasers comes with a more downtime but is more effective than the non-ablative lasers. Lasers can be used for the macular acne scar, atrophic acne scar, in which box scar is preferred, then the rolling scar and the ice pick scar. It can be used for the hypertrophic scars. Usually 4 to 6 sessions are advised at an interval of the 6 to 8 weeks, depending upon the type of lasers used and for the variety of the acne scars. Ablative continuous lasers include CO2 lasers, Erbium YAG lasers, fractional CO2 lasers, pulse Erbium YAG lasers, and the non-ablative non-fractional include ND-YAG, IPL, KTP, picosecond pulse diode lasers, and PDL of the various wavelength. Non-ablative fractional lasers include the erbium doped, erbium glass, and diode laser. This slide shows the various technique indicated for the various type of scar with the level of evidence and the strength of the recommendation. So, the hyperpigmented macular scars in which the topical retinoids and topical skin lightening can be used with the level of the evidence of the 1 and strength of the recommendation is A. Platelet plasma used for the hyperpigmented macular scar have the level of the evidence is 2 and the strength of recommendation is B. Hypertrophic scar in which the intralesional steroid is used with a level of evidence is 1 and with the strength of recommendation A. The ice pick scar in which the cross technique works well with the evidence 2 and the strength of recommendation B. Superficial atrophic scar in which the topical retinoid and chemical peel used have the level of evidence 3 and the strength of recommendation C. And the dermabrasion used for the superficial atrophic scar have the level of evidence 2 and the strength of recommendation B. Mild to moderate atrophic scar in which the microneedling RF energy devices PRP use have the level of evidence of 1 and the strength of recommendation A. Microdermabrasion and non-ablative lasers used for the mild to moderate atrophic scars have the level of evidence 2 and the strength of recommendation B. In case of moderate to severe atrophic scars, ablative lasers have the level of evidence of 1 and strength of recommendation A. And the punch excision which is used for the moderate to severe atrophic scar have the level of evidence of 3 and strength of recommendation C. Subcision which is usually indicated for the deep atrophic rolling scar with the subdermal adhesion have the level of evidence 2 and the strength of recommendation B. This synthetic fillers, autologous fat transfers used for distensible and lipotrophic scars have level of evidence 2 and the strength of recommendation B. Autologous dermal fillers have the level of evidence 3 and the strength of recommendation C. So the management of acne scar is very time consuming and any improvement occurs gradually. A patient will have the different type of acne scars. So various combined modalities and the multiple sessions required for the best result. Proper counseling before any procedure in respect to adverse effect outcome to match the patient expectation is needed. Thank you.